I only told Matthew to call you because I had listened to your talk at where was it, in Ooty?
Ooty, yeah.
Ooty, you had given an update on medulloblastima. So I told the
Yeah.
best person to cover everything, not radiology and surgery, of course, and post-op course, everything, updates. I think Suresh Babu can finish everything. Give him some half an hour to 45 minutes.
No,
But
I'm going to talk only
our,
on
our
surgery.
society is like that, so many people have to be included. But he can finish everything if he wants.
No, I'm going to talk only on surgery.
Fine. Okay, Suresh.
Yeah.
I think all the speakers are there. We should start on time. Okay, 10 minutes to go.
Hi. Sir, good evening, sir.
Hi, Deepak.
Hello, sir. Good afternoon, sir.
Good afternoon, Deepak. Nice to see you.
Nice
Your
to see you.
hairline is receding. Is it because of climate of Delhi?
No. It's because of
Sundar.
aging phenomenon.
Yes,
Good
yes.
afternoon, Sundar. Yes,
Good
good
afternoon.
morning. Yeah.
Okay, good evening, Deepak.
Okay.
Good evening. Good evening. Good afternoon.
Bijoy, Deepak Gupta is a professor of neurosurgery at All India, not that infamous All India Institute of Medical Sciences, New Delhi. So he's a pediatric neurosurgeon, one of the great surgeons of pediatric neurosurgeons of India.
Hi, sir.
Deepak Gupta, I was so fortunate. I happened to be everywhere for his examination, selection, everything, and always he always used to tell, if he cannot answer a question which people ask, he said it will be directed to Suresh Nair if I am in the audience. Always he used to tell that. But Deepak, I am looking forward to learning something from you. Oh, big boss has come. Datta Mazumdar.
Hello, sir.
Unmute. You have to unmute.
Hello, sir. How are you?
Fine, Mazumdar. Are you talking from Goa or from
No.
Mumbai?
I'm talking from Mumbai. Amchi, Mumbai.
So you didn't go to Goa?
No, sir. I didn't go. I just returned from Chandigarh for the pediatric meeting. No, we returned.
Okay.
And I'm going to this Dr. Sumit Sinha's meeting in Delhi.
Oh, that means I will be seeing you there, meeting you there as well.
Yes.
And Deepak also hopefully will meet there in Delhi, Sumit Sinha's meeting.
Yes, sir.
So, fortunately for me, actually I am an alumnus of Trivandrum Medical College. So, I am supposed to get the award as one of the distinguished alumnus of Trivandrum Medical College.
Yes. Congratulations, sir. Congratulations.
No, thank you. That is, I have to go.
Congratulations, sir.
So thank you. That came as a gift for me because otherwise I would have spent so much money to go to Goa for that meeting and all. I saved money.
So you are not in Goa.
I'm very much in my house.
Oh.
I think we can start now. The time is
right.
Okay.
Please.
So let me first welcome everybody to this NSI webinar. I'm Dr. Matthew Abraham and my co-host is Professor Dattarai Majumdar. Today's topic is management of medulloblastomas. Let me first introduce my co-chair, Professor Dattarai Majumdar. He is Professor and Head of Department of Neurosurgery, Lokmanya Tilak Municipal General Hospital and Medical College, Zion, Mumbai. He's familiar to all neurosurgical audience as well as to most neuroscientists of the country. He's a highly accomplished surgeon, a great teacher, and he's extensively published. His fields of interest overlap very much with mine, so I'm very close to him from an academic point of view also. His regions of interest are epilepsy surgery, neuro-oncology, and pediatric neurosurgery. Let me first request him to introduce the topic, medulloblastoma.
Thank you, Matthew, and thank you for the kind introduction. And as you know, Matthew has been a close colleague of mine for so many years, and he has been the professor and head at Sri Chitra Institute of Medical Sciences and a very accomplished. I've learned a lot of things of epilepsy surgery from him, and we share the same interest. That's what he correctly said. He's also a very great teacher, and he has been a recent examiner at SIAN also, and I think he carries Professor Suresh Nair's legacy of hardcore clinical neurology, and that was a great treat to watch and learn from him also. So with this today's topic of medulloblastoma, I think medulloblastoma was close to my heart because in our residency system in KEM, we used to get posterior fossa tumors to operate during residency. So by the time we finished our residency, we must have operated about at least 20, 30 posterior fossa tumors, medulloblastoma to be precise, in our 3-year residency term. And that time, because the routine list should not get disturbed and posterior fossa tumors were a kind of a semi-emergency, Dr. Goyal used to be there. He never used to like shunts or never used to like the patients to be kept waiting for surgery. So the surgery used to occur on the same day, same evening, same night, or maybe at the most early morning. But we never had this CSF diversion, pre-operative CSF diversion as a rule. Many a times only if the patient used to come in a very obtunded state, then only we used to consider that. But that's the reason medulloblastoma, we got a lot of insight in this, and our experience evolved in that. Now, medulloblastoma is what's considered as a primitive neuroectodermal tumor, and obviously because the prognosis was good, it's separated from the PNET group, especially in the posterior fossa, because it had good prognosis. Though it is a grade 4 anaplastic tumor, it's a good prognosis, mainly from the adjuvant therapy protocol, the craniospinal irradiation and the risk stratification, and so on and so forth. So it is important that as surgeons we know how much to resect and what time to stop, because if in posterior fossa the morbidity could be very high, and these patients do not reach the adjuvant therapy protocol where they could maximum benefit from maximum this thing as regards long-term prognosis. So as you know, over a period of time it got separated from ATRT as well, because ATRT confused with medulloblastoma used to downgrade the prognosis. So now ATRT, PNETs are separate, and medulloblastoma has further evolved into clinical radiological genomics and subgroups and molecular typing and all. So we'll hear all that from today from an this distinguished guest that we have and panel that we have. So I would request Matthew that with this short introduction, we should start the webinar, and he can introduce the speakers, and then we can have a panel discussion. Thank you, Matthew.
Thank you, Dr. Majumdar, for the introduction. The first talk is imaging of pediatric posterior fossa tumors and radiologically differentiating the variants of medulloblastoma. The talk is by Professor Bijoy Thomas. He is Professor Senior Grade, Department of Imaging Sciences and Interventional Radiology at Sri Chitra. He has 260 publications international. He has citations of 6,710. His H index is 39. His ITER index is 122. In other words, he's a radiologist whom the world is watching. He has several clinical fellowships from excellent institutions to his credit. He has a clinical fellowship from the Hospital for Sick Children, Toronto, Ontario, Canada. The Boyce Cast Fellowship in Functional Neurosurgery from Leuven, Belgium. The SNR Fellowship from Adelaide, Australia. He has certificates of merit from the Radiological Society of North America in 2007, 2008, 2011, 12, and 16. He has the Chairman's Appreciation Award in the Indian College of Radiology and Imaging, the President's Appreciation Award in the Indian Radiological and Imaging Association in 2021. And he has given the lecture, the lead lecture in the International Society of Magnetic Resonance in Medicine in Stockholm in 2010, and in the plenary lecture in 2016 in Singapore. He has extensive patents which have been related to Chitra's mandate. He is among the 2% global scientists in the Stanford's list of scientists. He's the joint editor of the IJRI and the editorial board of Neuroradiology. He's the president-elect of the Indian chapter of the International Society for Magnetic Resonance in Medicine. His fields of interest are advanced neuroimaging, pediatric neuroimaging. He's an ardent researcher and a teacher. He also does a lot of painting, and is a beautiful singer. And over to you, Dr. Bijoy.
Thank you, Dr. Matthew, for those words of kind introduction. Am I audible?
Yeah, you're very much audible.
Yeah. So today we will talk about tumor medulloblastoma. Medulloblast is actually a misnomer. So we're going to talk about a tumor which is very, very heterogeneous. It's not even a cerebellar tumor. Some of these subvariants are to be classified as a brainstem tumors embryologically. We'll discuss about that today. So from 1979 to 2021, WHO has actually reclassified the brain tumors several times. Now, mostly genetic classification along with the histopathology is existing, because the prognosis also depends on the genetic subclassification. So post-fossa tumors in pediatric and adult patients are different, and we can broadly classify them into embryonal, ependymal, as neuronal, meningeal, and all. But with the 2021 classification, this review article in European Journal of Pediatrics, again the same situation, but the embryonal tumors are classified into several subtypes, including previously we talked about the Wind, Sonic Hedgehog, as well as non-Wind, non-SHS groups. And now we have within Sonic Hedgehog itself, as well as the subgroups which are very different as far as prognosis is concerned. So for the interest of imaging, we will and time we will actually stick to medulloblastomas and some differentials. And as I've previously mentioned, they are very highly cellular tumors. All of them are originally classified as grade 4 tumors, but their prognosis also varied with the present understanding, even though they are all classified as grade 4 tumors even now. So one of the classical imaging features of them, when the tumor is having a high diffusion restriction, that means there is a reduced ADC value. When you look at these diffusion images, most of the time we look at only the diffusion weighted image, and we don't give much importance to the ADC map. Even when we are looking at the ADC map, we are thinking that it is an image. It is actually a parametric map. We can actually measure the ADC. Most of the time when you measure ADC, you can differentiate between many of the post-fossa tumors, because most of the ependymomas, can be differentiated from medulloblastomas. Pilocytics definitely can be differentiated, and this is an important parameter which we should all do. Classically measure the ADC, go to the radiology workstation and measure the ADC. Most of the time, medulloblastomas have an ADC of 0.8 into 10 raised to minus 3 millimeter square per second of diffusion, apparent diffusion coefficient value, whereas most of the other tumors will have more than 1. The posterior fossa. They are known for more than a century. They are the blue tumors because they have got a high nuclear cytoplasmic ratio. They constitute about a large percentage of posterior fossa tumors, and also one of the leading causes of morbidity and mortality. And in the 2007 WHO classification, where it was actually histopathologically classified and into classic medulloblastoma and variants. So it was thought that the anaplastic medulloblastoma has got a very bad prognosis, and so also the large cell, but the classical has got a relatively better prognosis. But as we understand the genetics of these tumors, we understand now that when they are of the Wind subtypes, even large cell anaplastic medulloblastomas are also having a relatively better prognosis when they are actually coming in the group 3 or group 4 medulloblastomas. So this is a classical risk stratification. When we talk about imaging, we are talking about the pre-surgical imaging, and also whether we can predict that the prognosis for the patient, and also design surgery, because like previously the chair has actually mentioned, these surgeries can have significant morbidity for these patients, because they can be adherent to cranial nerves and the brainstem. They can have significant brainstem problems, and also the adjuvant therapy is actually going to keep them in long-term morbidity. Many studies have pointed out that the Wind subtype of medulloblastomas, their outcome is 5-year or a later outcome is actually mostly constituted by the difficulties caused by adjuvant therapy rather than the original tumor itself. So the original idea was actually to keep the minimum post residual tumor, and the prognosis was basically based on metastasis was there or not, and the extent of the residual tumor and the age group. Now we know that this is not true, and many of these are really possible to be optimized based on the immunological, immunohistochemical, as well as genetic characteristic of these tumors. When 2016 classification came, there is molecular-based classification has first come to WHO classification, even though the initial research was going on much earlier. Even in 2007 Lancet paper, there was subclassification of these medulloblastomas, but it has come to WHO classification only in 2016 for the first time. Now it is almost continuing in 2021 with some modifications. So this was the first neuro science literature which is showing that talking about them, the medulloblastomas and their molecular subtypes. And later in 2012, this paper in Acta Neuropathology just showed they have detailed description of these tumors. So that time these post-refosa tumors were classified into medulloblastomas, ATRTs, these embryonal tumors, and also ETANTR. But that is actually disappeared now. Embryonal tumor with the abundant neuropils and true rosettes is disappeared. So now we know that this is all classified into ETMRs. So this is the ACTA paper which says that classified this. Even now this is very relevant, and we know that they have actually classified based on the demographics and based on the histopathology, and also based on how they are actually can be classified into these subgroups of based on immunohistochemistry and genomics. So these Wnt subtype of medulloblastomas, they occur in children and adults and not really in infants. Most of them are classic and rarely large cell anaplastic, and has got a very good prognosis, especially when optimal surgery and chemoradiotherapy is done. And the Sony hedgehog, this is the only subtypes where all the subtypes of histopathological subtypes are there, and which can occur in any age group, and mostly in infants and older age group. And older age group, this is one of the common desmoplastic tumor. And when you see desmoplasia, most of the time, most of them are Sony hedgehog, and so also the medulloblastoma is extensive nodularity. And group 3 has got the worst prognosis. There may be central small tumors, and which shows enhancement, and group 4 also has got a relatively bad prognosis, but we will talk about that in detail more. So even now in the era of radiogenomics, the real estate rule in brain tumors is very much relevant. What is the real estate rule is location is money, and in brain its location is prognosis. This is especially true in supratendural tumors, but also true in the infratendural tumors. So when we actually classify these tumors, we should know a little bit of embryology basis of development of these tumors. So in the developing brain, when the neural tube develops, there are different vesicles are developing, and the prosencephalon, mesencephalon, and rhombencephalon, and the cerebellum we know develops from the rhombomere 1, and the brainstem nuclei are developing from rhombomere 2 to 8. And in the rhombomere 1, there are two embryonal germ cell centers are there, which is actually the rhombic lip and the ventricular zone. The GABAergic neurons are actually transported across the cerebellar hemisphere in the central part radially from the ventricular zone, whereas in the from the primitive neuro, the extra granular cell layer is actually traversing tangentially in the cerebellum, and that is how in the tangentially in the cerebellum they form the external granular cell layer, and later guided by the sonic hedgehog pathway, they are actually growing into that through the Purkinje cell layer into the internal granular cell layer. And this pathway is actually contributed or guided by the Sony hedgehog, and this GABAergic pathway is guided by many signaling pathways, including that of a Wnt pathway. And this is why the the sonic hedgehog pathway medulloblastomas has got a developmental origin. That's why, because they are actually transported from the external granular layer to the internal granular layer, they can occur anywhere in the periphery of the tumor, or also sometimes in the central, depending on the migratory path in which they are actually transforming into. These mutations are actually transforming into medulloblastomas. So that's why this location has got a specific embryological basis. It's not a random occurrence, but there is a specific embryonal basis compared to the wind pathway medulloblastomas. They are actually can occur from the center to the through the CP angle, through the lateral recess, and that is because they are guided. And it is also the Nature paper, which again talks first about these medulloblastoma subtypes and how the developmentally they are actually related or separate. And for example, the wind pathway medulloblastomas with the Salt and Pate's paper, they are clearly showing that they are not a cerebellar tumors. They are actually brainstem nuclear tumors, because they are actually from the lower rhombomeres, and they are actually guided by the wind pathway and not by these other pathways. We are not very sure about the embryological basis, even though later papers are throwing some light, because from the wind or the sonic hedgehog, compared to that, group 3 and group 4 are the embryological basis of these tumors is less well known. But we know that the group 3 tumors are relatively smaller tumors. Both of them occur in the central part of the fourth ventricle, the floor, or the from the roof, and depending on their embryological origin again. And you can see that the group 3s are more tend to enhance, like a fluffy cotton wool like enhancement. But also there is significant overlap. These are all statistical maps. The best prediction is only 60 to 70%, and most based on location is only in depending on the sonic hedgehog, it is around 60%, and wind it is around 30 to 40%. So anything less than 50% is not actually a prediction. So this is just a statistical occurrence which we are actually talking about. We know that these pathways, actually signaling pathways, are actually going along a line, so they can occur anywhere. So we only tend to get arrested in one particular area, and we think that this is some of the features, like beta catenin expression is more common in wind pathway, in the microvascular development. So there is, if pathway medulloblastomas, and an excellent prognosis, especially when you take down your chemoradiotherapy doses, because the outcome and need not be resected completely, can lead on to more morbidity because of more cranial morbidity. And also it has been shown that other than sonic hedgehog, group 3, group 4, as well as the wind pathway medulloblastomas, when extensive surgery is done, the cerebellar mutism chances are also high. So also that also depends on how the dendritic thalamocortical connections are also organized in different patients. That can be complete absence, or the dominance on one side and all. So this is a very interesting topic. So that is that the new insight from these embryological tumors, how that surgery can be tweaked, how chemoradiotherapy can be tweaked based on this. That's why the preoperative prediction is very, very important, and all of them can be diagnosed with methylome sequencing, or with immunohistochemistry and a genome wide analysis. All of them can be classified, but whether you can preoperatively diagnose so that optimal surgical therapy can be done is the question. Sonic hedgehog is another pathway which we have actually discussed about them, and the role in development of sonic hedgehog medulloblastomas. This is the only, like I've previously told, this is the only subtype of medulloblastoma where all histopathologies can be found, and the outcome is intermediate between the other tumors, and it is definitely not as good as wind pathway. Wind pathway, again, it is different, and also it is also important whether their TP53 mutation status, and also then group 3 there can be mican amplification. So all those this subclassification is also becoming very, very important, and they are also becoming into very heterogeneous groups, and I'm sure that very specific personalized therapies may emerge very soon based on, and new immunotherapy techniques also maybe will be developed soon. But having said that, their overall prognosis has not actually improved significantly, partly because we were very reluctant to tweak our chemoradiotherapy strategies in these tumors. Because they were all great for, we thought that we can do craniospinal radiation in a very young child, and we were not thinking about, we not like that, because but recently only the evidence has emerged that we can actually scale down these chemoradiotherapy strategies. So like I told, group 3 medulloblastomas are the worst prognosis. They can show metastasis at the time of diagnosis itself. They show very classical metastatic patterns, which I will discuss. And this is the heat map. The radiologists are interested in radiogenomics. They are statistical maps. Based on these heat maps, you can say that which one is occurring where. But this is just a statistical map, and it is really difficult to predict in individual cases many of the times. So like I've mentioned, there are several other features also. The edema is more classically seen in Sony Hedgehog, small primaries in group 3s, sugar-coated metastasis in group 3, mismatch metastasis in group 4. That means the original tumors may not show enhancement, but the metastatic tumors show enhancement. And we were talking about the location in one plane, the axial plane. There is a recent study from Tata Memorial which also talks about that the supra-inferior the orientation. So the Sony Hedgehog medulloblastomas, in addition to being peripheral, they are more superior, and the wind pathway medulloblastomas, in addition to being going into the CP angle, they are all tending to be lower. And between group 3 and group 4, they are also central tumors, but group 3 is higher in location, smaller in size, more in enhancement. Group 4 is lower in location, and that is also contributing to their differential diagnosis. So this is the paper I was talking about, the Sen Dasgupta's paper. Which they talked about further interest from just by sight and radiomics differentiation. So when we see this, this is a fluffy enhancement, and you can see there is central tumor. This is most likely a group 3 medulloblastoma. You have to specifically look for a spine, the entire neuraxis for any small metastasis, because sometimes this metastasis can be very small deposits in the end of the thecal sac. You have to be very careful, do the fat sac sequence and do the study properly. And the preoperatively itself, you have to do that the entire neuraxis screening with contrast, and also postoperative scanning should be within 24 to 48 hours in order to see the completeness of the scan. This is what I've told about even though some enhancement can be seen in group 4 tumors, they are lower in location. That's why the superior recess of the fourth ventricle can be dilated in group 4 tumors. This is another radiological feature which is actually described. And when we see a lot of edema, more than 1.5 centimeter of edema around the tumor, it is more likely to be a Sony Hedgehog tumor, even when they are at the central location. So these are some classifications, and the perfusion is not really going to differentiate, but we have seen that group 3 tumors show some increase in perfusion. Most of the medulloblastomas perfusion may not be very high, and they can also show sugar coating metastasis, because when they can be completely gadolinium enhanced, they can, the T1 weighted post-contrast scans can mimic a T2 weighted scan. And this is what I told about. There can be skip lesions, there can be thecal sac enhancement at the lower end of the sac. There can be, because of the CSS spread, it can go anywhere. And compared to the group 4 medullos, their metastasis at the time of diagnosis may not be high, but you can see when they metastasize, the tumor assets may not enhance, but they can show enhancing metastasis. And especially in you have to also look at the third ventricular and the supracellular regions, and the enhancing tumors metastasis always enhances in, that's called a mismatch metastatic lesions in group 4 medulloblastomas. So having said that, the advanced neuroimaging is not helping us much, but when you see this perfusion is usually low. This is a peripheral tumor, diffusion restricted tumor. We see that the fractional isotropy is very high. The fractional isotropy is in the high because they are fibrous desmoplasia in these tumors. And we see this very high choline and almost near complete absence of NAF. When you see this extraaxial looking spectroscopy, it is more likely to be an embryonal tumor. And this is the histopathology of these tumors, multiple nodules. And this is desmoplastic medulloblastoma previously used to call. Now we know that almost 100% of these desmoplastic medulloblastomas are of the variant of Sony Hedgehog. You can directly make a diagnosis of a Sony Hedgehog medulloblastoma in these cases. And one word of caution, Lermite-Duclos disease sometimes can mimic because sometimes these this can be slightly different, this corduroy-like appearance, but especially when you are looking at SWA, there can be Swiss pains in Lermite-Duclos disease, which we published many years back. And the Lermite-Duclos disease diffusion restriction may not be there. So if that is what when you are looking at only the diffusion images, you tend to think that this is diffusion restricted. But if you look at the ADC is actually higher than the rest of the cerebellar parenchyma. You have to actually measure. I'm sure that's definitely more than 1 × 10⁻³ millimeter square per second. And they are unlike they are lower grade tumors, they show very high perfusion, and this should not be mistaken for a high grade tumor. So this Lermite-Duclos spastic cerebellar gangliocytoma. And sometimes this corduroy-like appearance can come in medulloblastomas. You have to look at measure the ADC, it's less than 0.8, and you can see that the spectroscopy, and this is a Sony Hedgehog medulloblastoma. And this medulloblastoma with extensive nodularity are also Sony Hedgehog medulloblastomas, and that is again very important. So what is the risk stratification now? In 2023, this paper from European Journal of Pediatrics, they are low risk, standard risk, and high risk, and based on that, they have actually strategized different therapeutic planning. And I think every neuro-oncology society has also their own recommendations. The Indian Society of Neuro-Oncology has got a consensus guidelines or contemporary management of medulloblastomas. But the problem is not that. There are several mimics. For example, this is a central tumor, diffusion restricted, hemorrhage is there, and this is entirely an extraaxial tumor. This turned out to be a Niving sarcoma. And this is a CP angle tumor which showing some necrosis, which is going into the brainstem. Whether this is a Wnt pathway medulloblastoma, no, it is actually a diffuse midline tumor. So it's a S3K27 tumor. So preoperatively diagnosing them almost 100% by imaging alone is not possible, but we have to be very, very careful. But when possible, when we have actually, then we have to make a differential diagnosis. ATRTs are a great mimic. It can occur in the supratentorial compartment, infratentorial compartment. They can show hemorrhage. They can produce diffusion restriction. They can mimic a medulloblastoma, yes, but they also show very low Na and a very high choline and a lipid lactate peak. And pilocytics, again, we thought they are low-grade tumors. Now we know that the BRAF CV600E point mutation can be there. They can, because the high-grade gliomas with payload features are also come in the new classification. But there is a paper recently published which talks about advanced MR sequences like CEST imaging can differentiate from brainstem pilocytic from diffuse midline glioma, but in our experience, it is very, very difficult. Again, it is based on location, more ventral location, diffuse involvement, actually engulfing that the basilar artery may be a more diagnostic sign for a diffuse midline glioma. We will not talk about that. So having said that, there are no definite these things 100% accurate imaging predictors for that. Now the next 2 minutes, we will talk about ependymomas. Even though they can be differentiated from medullos most of the time, some cases it is not that easy, and which I'll show 1 or 2 examples. And also this, there can be supratentorial CFDA fusion abnormalities or YAP1 abnormalities in the posterior fossa. They are classified in the posterior fossa A and B, and then now these got the spinal myxopapillary ependymomas with the myelin amplification. It's also high grade the ependymomas. So when we talk about the posterior fossa ependymomas, the group A, the posterior fossa A type A ependymomas has got a worse prognosis. They occur in young children, but there is also a side predilection. They tend to be more lateral. So they actually share the location with the Wnt pathway medulloblastomas, even though their diffusion characteristics may be very different. Their calcification strategies, stratification may be different. So that they show the paranuclear dot positivity for the EMA, and also S3K27 ME3, there is a loss of nuclear expression compared to later onset group B, type B, or apostrophe type B ependymomas, which are more central in location. They are also not 100% accurate genomic, radiogenomic features, but here you can see that S3K27 ME3 nuclear expression is preserved. So they can be only diagnosed with immunohistochemistry, with the genomics, or with methylome sequencing. But we should, on imaging, we should make an attempt because the prognosis is different. And when you see calcification, when you see less diffusion restriction, and all these tumors, ependymomas, medulloblastomas, even lower grade tumors like choroidal papillomas, neuroaccess screening is really, really important, because sometimes that the metastasis can be very small dot at the fag end of this thecal sac. So you have to be very, very careful. Otherwise, if you miss this, the appropriate therapy will be can be missed. So imaging genomics, where do we stand now? Based on location, radiologist perception, very difficult in our opinion to differentiate them, but we can make an attempt. But the Asian Oceanic Society of Neuropathology has also come with because it is very expensive to do all these immunohistochemical stains, and definitely a methylome sequencing. So they have also come up with the guidelines on this. But what radiologists are really interested in doing is that computer-based, the AI-based algorithms, which can more accurately predict, and it is still it is not completely achieved. But I think with more especially when the more and more subtypes are coming up, I think whatever algorithms are trained, they have to be retrained, and this is a never-ending story. So I jokingly say that as long as pathologists are there, we will not lose job as radiologists, because AI can never take over, because they keep changing their classification every other day. So this is the last case I'm going to show. This is a tumor in the posterior fossa. They are not showing much of a diffusion restriction. ADC is not high, and you can see there is it is going into the CP angle both sides, and there is a faint enhancement. Is it a medulloblastoma, or is it an ependymoma? And this turned out to be a medulloblastoma, non-Wnt, non-SHH. So whatever we are talking, when the medulloblastomas are very highly cellular tumors, sometimes they may not show that diffusion restriction, that it is a lesson, because we reported this as an ependymoma most likely because of the diffusion characteristics. But CT also showed a hyperdensity, and hyperdensity in this case. In this case, CT was more useful to diagnosis as a medulloblastoma. So with that, I would like to stop. These are the unmet needs: more accurate genome preoperatively itself. There are specific molecular-based MR contrast media are being developed, but it is under development for many. This optical hybrid imaging and optical as well as MRI hybrid contrast media are getting developed, because if we can actually do an immunohistochemistry staining, can also be done in an MR contrast and optical contrast, and guided therapy also may come. And post-therapy imaging is also very, very important, which I have actually not covered. And thank you very much for your kind attention.
Thank you, Dr. Bijoy, for such a wonderful talk. I must admit your concepts are so robust and clear. Our next talk is on surgical management of medulloblastoma. The speaker is Dr. Suresh Bapu. He is one of the most well-known surgeons in India. He is a mentor for many young neurosurgeons in Tamil Nadu. Currently, he's Director, Institute of Neurosciences, SIMS Hospital, Chennai. He has done his MBBS from Madurai Medical College. He has his MS and MCH neurosurgery is also from Madurai Medical College. He was trained under Professor Yasser in the early 80s. Under the guidance of his Professor M. Nadarajan, he started the microneurosurgery program in Madurai, and which have trained a large number of young neurosurgeons. He was then additional professor of neurosurgery in Madras Medical College and Government General Hospital. He left government service in 2006. He has worked initially as a senior consultant neurosurgeon in Apollo Hospital, Chennai. He's extensively published with more than 75 publications. His fields of interest are endoscopic surgery for pituitary tumors and skull-based tumors, and total excision of CT angle tumors with functional preservation of facial nerve. Indeed, a very difficult region. Over to you, Dr. Suresh Babu.
Good evening to all. I thank the NSI Webinar Committee for giving me this opportunity. I will restrict myself to the surgical management of the medulloblastoma. Of course, we saw it's an embryonal tumor, and it is a commonest malignant tumor of the brain in children. It has got 2 peaks at the age of 3 and 4, and then 8 and 9. But it also occurs in adults in the 3rd and the 4th decades. But in adults, it forms less than 1% of all adult CNS tumors. It has got a male preponderance of 2:1, and you saw that it is not a single entity, and Dr. Bijoy has explained in detail the various aspects of the subgroups of WNT, SHAs, and the subtypes of that, and the location. So it is not a single entity. It's a heterogeneous group with different cells of origin, sites of origin, mutations, genetic markers. We saw all these things in Dr. Bijoy's talk. Clinically, they present with a raised ICP and ataxia, usually occurring in a matter of a few days or a few weeks in a subacute manner. The ICP features are usually a headache and a projectile vomiting. Even now, even today, we see a lot of kids who are investigated with ultrasound of the abdomen and gastrointestinal scopy procedures before imaging of the brain is done to diagnose that. That's a very common situation even now. The clinical hallmark is the ataxia, the truncal ataxia. It can be gait ataxia, stance ataxia, or it can be just incoordination of the limbs. The diagnosis clinically may not be very evident in small children and infants. They may just present as irritability, delayed milestones, and with a large head. And sometimes we see patients with isolated 6-nerve palsy, torticollis, visual loss. All these things have been described. In the pre-surgical workup, neuroimaging is a most important thing in the pre-surgical workup. But I would like to just warn the juniors that some of these kids are so sick that if you don't resuscitate, if you don't intubate and then send them, sometimes we may find that the kids may go in for respiratory arrest in the MRA room. So whenever there is a doubt, we intubate, ventilate, and with that, we do the imaging study. In such circumstances, probably we do CT scan first and then defer the MRA at a later stage after initial assessment and the management. Of course, CT and MRA gives very good anatomical diagnosis, its extent, and you can see extension, all these things. But we can guess, as Dr. Bijoy said, the pathological diagnosis and the molecular diagnosis. But ultimately, we need the histopathological proof and need for the surgery for all these patients to make a definite diagnosis. If you see the timeline evolution of the therapy for medulloblastomas, so before 1940s, the mortality rate was very high. And then the things started changing when in addition to the conventional surgery, craniospinal irradiation was started. And in 1980s and 90s, the outcome became much better. That's but also because of the microsurgical advances, the neuroanesthesia techniques, ICU care, all these things were responsible, and we got this result. Definitely, it is attributed not only for the radiation techniques improvements, but also because of the advances in neurosurgery, neuroanesthesia, and ICU care. So we have many guidelines. We have got ISNO guidelines. We have European oncology guidelines. We have Spanish guidelines. We have pediatric guidelines. But if you see, the surgical management remains the same in the past 30 years or so. There has been no gross recent advance in the surgical management. Of course, we have surgical navigation, we have intraoperative MRI, we have intraoperative ultrasound. They are all useful adjuncts, but they are only rarely indicated. And of course, they are useful in small, deep, laterally located tumors, and probably in revision surgeries, which is done very rarely. The aims of surgery is to first establish the histologic diagnosis and get tissue for molecular subtyping. And this is a very important part because it decides the further line of management. Most of these children, they present with hydrocephalus. So relief of CSF pathway obstruction and the control of intracranial pressure is one of the important aims of the surgery. And once the surgery is done, only we can start radiotherapy, and chemotherapy will be facilitated. We all know that for gliomas, extent of resection influences the outcome. Now, does this apply to medulloblastoma? Yes, certainly. So the study long ago showed in 1999 that the important factors in the outcome is if the residual tumor is less than 1.5 cc, then progression-free survival 5 years is 78%. And if it is more than 1.5 cc, then it is 54%. Based on that, the clinical radiological staging was done at that stage as a standard risk, the residue and the metastasis. Now, we know gross total resection and near total resection have good outcome. On the other hand, we know partial resection, that is the tumor is more than 1.5, then it's a poor outcome. But what about the subtotal resection? If a patient undergoes subtotal resection, that has badly influenced the outcome. Now it is felt that the more than the extent of resection, molecular and genetic expressions correlate more in the extent than the extent of resection in the overall outcome. Eric Thompson's article also has shown that there was no significant survival benefit for greater extent of resection for patients with WNT-SHs and or group 3 medulloblastomas, whether it is a subtotal resection or gross total resection. Only in group 4 medulloblastomas, gross total resection offered better progression-free survival compared to subtotal resection. So even there, overall survival, there was no difference. However, before surgery, we do not know the exact histopathology and molecular subgrouping. All these things is known only after the histological examination. As a surgeon, before surgery, we have we can guess, but we are not sure. So the aim of the surgery will be the maximal safe resection will be the goal, but we have to avoid the neurologic or systemic and wound complications so that the craniospinal radiation and maybe chemotherapy can be started as early as possible. So the initial management, when the kid comes with features of raised ICP with headache, vomiting, and drowsiness, we start the patient on the steroids and the osmotic agents when necessary. And if the hydrocephalus is large, and if there is going to be a delay in tumor surgery over a few hours or 1 or 2 days, then either we do external ventricular drainage or preferably we do an endoscopic ventriculostomy. One of our patients they're visiting from US. The child was diagnosed as a medulloblastoma. They had to go 2 days later. So in such cases, we did endoscopic ventriculostomy, and the child was fit to travel 2 years to get treatment. In generally, it is said that we should avoid VP shunt now because the VP shunt is a known devil with complications of shunt infection and upward migration. Not only that, they also sometimes get the abdominal peritoneal drop metastasis. Metastasis can occur if VP shunt is done before removal of the tumor. The surgical approach has been a standard midline suboccipital craniotomy with a C1 post-arch excision. In most of the patients, it gives good access to the tumor. If the tumor is completely lateral located, you may change the strategy and do a more laterally placed craniotomy. But midline suboccipital craniotomy is the one that is done in most of the situations. And of course, the anesthetist has to be very careful that the eyes are protected, the endotracheal tube is firmly fixed, and so that it doesn't slip out. And of course, we prefer prone position in children more than 4 to 8 years. I mean, we use a 3-pin. Otherwise, we have to use a horseshoe to prevent the skull perforation by this 3-pin head clamp. Of course, we prefer prone position as most of the institutions, but of course, in some of the centers, sitting posture is used, and with equally good results and no adverse events. Dr. Majumdar has presented this one. Of course, we all use a WHO safe surgery checklist in all our patients. And once the midline incision is made and the craniotomy is done, we make a Y-shaped durotomy. And when we expose there should be careful when you open the circular sinus bleeding can be very, because we have to be very careful. The tumors arise mostly in the region of the inferior medullum and the rhombic lip. So, and they grow towards the foramen of Magendie, and also they grow into the ventricle. And this is a very common situation there. So a patient is presenting like this, then we open the arachnoid, and the first step is to see whether we can find out whether the tumor is adherent to the fourth ventricle. Usually there's a good plane of cleavage. There is the interface between the normal brain and the tumor is well seen because it's a grayish appearance, or you can see the choroid plexus there, and we can separate. It's a circumferential dissection and careful debulking of the tumor, hemostasis. The assistant surgeon also a very important role in holding the tumor and gentle retraction. It is a 3 or 4 hand technique which helps rapid removal of the tumor in such cases. And there's a good plane of cleavage in most of the situations. And we are humors at the end. We should see the CSF coming through the aqueduct, and the floor should be seen clearly. All the residual tumors or whatever is seen has to be removed. So using a bipolar coagulation, the sperm saline irrigation, and using hemostats usually, and then we usually try to close the arachnoid by welding the arachnoid like this, and postoperatively, of course, we do MRI in most of the patients, but this patient had a CT scan done, the specimen. Sometimes the tumor is not seen initially, but once you retract the tonsils, the tumor can be seen, and it is removed the same way by there's a good plane of cleavage in this patient. Also, we were able to remove the tumor by the circumferential dissection all around, devascularization, and debulking of the tumor, and the tumor is removed carefully, and at the end of this surgery, there should be a clear CSF flow through the aqueduct, and there should be a perfect hemostasis is achieved in these patients. So when the brainstem is invaded, we leave behind a small portion of the tumor. We use in such cases, we use the insulated suction and probe for intraoperative neuromounting to see whether the facial nucleus is to simulate that, and then leave behind a small portion of the tumor there. Sometimes now tumors, they do not grow towards the foramen of Magendie, but they grow mostly into the intraventricularly. In such cases, we may have to use expose the fourth ventricle to the through the telovelar approach or the trans-Vermean approach. The telovelar junction refers to the junction of the inferior medullary velum to tela choroidea, and if you have the inferior view of the cerebellum after removing the tonsils, you can see the butterfly-shaped inferior medullary velum superiorly and the tela choroidea inferiorly. This is the telovelar junction. The choroid plexus is attached to the ventricular surface of the tela choroidea, and tinea is the line of junction of the tela choroidea to the infralateral margins of the fourth ventricle. In telovelar approach, both tonsils are separated. I mean, we don't exercise that, and the uvulotonsillar and the medullotonsillar, the spaces, clefts are dissected bilaterally, and pica is followed. Then the fourth ventricle is opened by incising the telovelar junction, and tumor resection is done. In trans-Vermean approach, the tonsils are separated, exposing the inferior vermis. A few millimeters of the vermis is split to enter the fourth ventricle, and a tumor resection. Of course, this approach is difficult to access tumors extending along the lateral recess, and it can cause cerebellar mutism and gait ataxia. So the essential steps during the gross total resection is identifying the floor of the fourth ventricle in the initial stages and protecting it. The microsurgical dissection along the tumor-brain interface. Then we should avoid blood spillage into the aqueduct and into the spinal space by placing gel-form patty. Circumferential dissection, progressive debulking, and meticulous hemostasis are key for successful outcome, post-operative outcome of these patients. And at the end of the surgery, there should be a free flow of CSF through the aqueduct. Intraop ultrasound we have used in some patients when the tumor is small, deep, laterally located, and in one of the division surgeries we used. So if you know, the mind knows that the eyes can see, that applies very well to intraoperative ultrasound. We can see the fourth choroid plexus, the tumor. We can even see the brain. Some even internal artery canal can be made out in the sagittal and coronal. When we use the 8C, the neonatal probe for intraoperative ultrasound, and at the end of the surgery, we can usually see the resection cavity and make sure there is no residual lesion. But this is not required in most of the situations. It is required only when there are smaller laterally placed tumors. Otherwise, it is not required in many situations. The dural closure is done usually it's with a pericranium, fasciolata, or dural substitutes. We tell the nurse at the time of timeout that they should keep a separate tray for the exposure of the fasciolata, thigh fasciolata, and this is used as separate tray so that we don't principles of surgery, we don't contaminated area or malignants, we don't want to put it to the thigh. We usually replace the bone flap and fix it with the titanium mini plates and screws. Though there is objection that can be metal artifact can be caused because of the metal clips, but usually it is not an issue to diagnose the residual tumor. Tight facial closure is very essential to prevent pseudomeningocele and CSF leak. The skin edges we approximate with 30 or 40 ethylene. If there had been hydrocephalus and if you have put EVD, we keep it closed and we remove only next day after ICP monitoring for a few hours. Post-operatively, all these patients are monitored in PICU or neuro ICU, and we continue steroids post-operatively for a few days. Prophylactic antibiotics, analgesics, nutrition, and ambulation are also taken care. Surgical site wound care is also very important. In spite of doing this, relieving the CSF pathway obstruction, sometimes in 10% of the patients, there can be a persistent hydrocephalus, and repatient may be required in these patients after a few days. Usually, whenever possible, we advise post-operative MRI, contrast enhanced of the brain is done soon after the hemodynamically the child is stable. And if the whole spine study has not been done preoperatively, then it is done in the immediate postoperative at that time. And postoperative workup should have, if supposing the MRI was not done in the immediate, the same day or the next day of the postoperative period, then it's done usually after 2 or 3 weeks time, and to assess the residual tumor volume and the metastasis. And if there is no spinal metastasis in MRI, then we do lumbar puncture and to see the CSF cytology after 2 to 3 weeks. If done earlier, it may show false positive, so it is done only after 2 or 3 weeks time. If the specimen need detailed histopathology, immunohistochemistry, molecular and genetic studies. As was said earlier, in most of this we do immunohistochemistry, immunohistopathology, but molecular and genetic studies are not generally available in a lot of the institutions. We have a discussion with a multidisciplinary tumor board meeting for the staging and risk stratification. And we use this standard risk, low risk, and very high risk for these patients. And then, of course, the modified Chang staging is not used now. To talk about the postoperative complications, the mortality has been reduced to less than 1% in most institutions. Of course, blood loss, brain stem injury, cerebellar peduncular injury, air embolism, if not treated appropriately, can become fatal. So the immediate early postoperative complications are related to wound dehiscence, CSF leak, meningitis, pneumonia, urinary infection. All these things are to be avoided, and if it happens, it has to be treated as early as possible. So that our aim is to start radiotherapy as early as possible by third or fourth week of time. Cerebellar mutism occurs in 10 to 15% of the patients. So it's a post-fossa syndrome or Venn split syndrome. It characterizes it happens usually, it is evident not immediately, but occurs after a few hours or the next day, in which there's a patient has got a decreased or absent speech. There is a hypotonia, there is a apraxia of swallowing, ataxia. And of course, most of these patients recover in 2 to 4 weeks time, but dysarthria may persist. The mechanism is said to be due to the injury to the dentate nucleus or dentatorubrothalamocortical projection fibers. It's said to be more common after transvermian approach than telovular approach, but it is not usually the amount of the vermian incision is so small it may not matter much. See, is it possible to map the dentate nucleus by intraoperative neuron monitoring? There are some attempts we have done, but still it is not standardized well. Example, when we start, we do MEP, the transcranial MEP, and see whether it is we get a good response. And then you stimulate the dentate nucleus, which will inhibit the cortical neurons, motor cortex. And then if you do transcranial MEP, then it will be absent. So this is called a collision mapping. The immediate preceding dentate stimulation will inhibit transcranial MEP. This is still not well standardized, and it is difficult to do that. We have done, but it was a negative mapping, so we are not sure whether it really worked in that patient. Of course, we should avoid the complications related to surgery, because it has been shown that surgery-related complications, the cognitive and psychological sequelae independent of radiation factors. We know that the field of radiation, the age at which the radiation is given influences the cognitive outcome in these kids. But surgery-related complications also increase that, so we should avoid the complications due to surgery by all means. After all, you see, cerebellum has got 4 times more number of neurons than the cerebral cortex. And cerebellum is not only for movement and balance, but also plays important role for the cognitive, emotional, and behavioral functions of the brain. Talking to the recurrent medulloblastoma, it occurs in spite of all the advances. 30% of the patients have recurrence and they got a very poor prognosis. Usually it is a craniospinal metastasis, but it can be confined to posterior fossa. Surgery is sometimes done for recurrent MBO only in very select patients. In one of the studies, it was done in 25% of the cases. If there is isolated localized recurrences in posterior fossa, relapsing after a few years of treatment, then it's an indication for surgery because we can maybe can avoid re-radiation, and it sometimes you get second malignancy, radiation necrosis. All these things can be excluded. If not by radiologically, by pathologically, we can do that. So it also identify molecular subgroups for targeted therapy, which are likely to available soon in a wide manner. And of course, we had one patient who was operated first in 2018, and she declined craniospinal irradiation and opted for native treatment, but returned 8 months later with recurrence. So this patient, we had to operate because then, of course, the role of surgery for spinal metastasis is very rare and very doubtful value. There are select patients have undergone surgery for spinal metastasis. Sometimes the spinal tumor is the recurrence is more in such cases for symptomatic relief of the myelopathy. It can be done, but the role is usually not clear. So the take-home message. So it is a teamwork. So the neurosurgeons have to do their job. What the expectations of the oncologist. So we have to do maximal safe resection, gross total resection, near total resection, or if not, at least subtotal resection. We should aim zero mortality and low morbidity. We have to do post-op contrast enhanced MRI with the spine staining within 24 to 48 hours. And if there are no spinal metastasis, the MRI, LP-CSF cytology is usually recommended at 3 weeks. Complication avoidance is essential to start craniospinal radiation by 4th week. Wound dehiscence, CSF leak, sepsis, they all lead to delay in starting. Of course, cerebellar mutism itself is not a contraindication for starting radiotherapy. Thanks for the attention. I thank my team for helping me, Dr. Syed, Dr. Deva, and Vishwa for helping me to prepare this topic. Thank you.
Thank you, Dr. Suresh Bapu, for a comprehensive talk and for the wonderful videos that you have shown. Our next talk is on recent advances in adjuvant treatment of medulloblastomas by Dr. Yamini Krishnan. Dr. Yamini Krishnan is currently the Senior Consultant and Head of the Department of Pediatric Hematology, Oncology, and Bone Marrow Transplantation at MVR Cancer Center and Research Institute at Kozhikode. This is a wonderful institute which has changed the approach towards cancer in the northern part of Kerala. The previous positions she has held include consultant at Lisi Hospital, Ernakulam, Kuwait Cancer Control Center, and Lakeshore Hospital, Ernakulam. The other current positions that she holds in the field of oncology include she's chair of Neuroblastoma Subcommittee, Indian Pediatric Hematology Oncology Group. She's chair of the Clinical Trials and Protocol Committee, Indian Childhood Cancer Initiative. And she's also the advisory board member, Asia, Australia, Africa Advisory Board, Advances in Neuroblastoma Research Association. Over to you, Dr. Yamin.
Thank you, Dr. Matthew, and thank you for the introduction. I would like to thank NSI and Dr. Matthew for inviting me to be part of this august gathering. I'll try to go through my topic, that is adjuvant treatment of medulloblastoma, in 3 parts. That is one, the roadmap until now, the current management, and recent advances. So the medulloblastoma history starts with the discovery of medulloblastoma by Cushing and Bailey in 1926. Later in 1950s, the classical treatment as we know it, that is craniospinal radiotherapy, was discovered. And the 3-year survival of medulloblastoma, which was until then a very poor prognostic tumor, increased to 60%. And by 1969, the Chang classification, as we know, for the staging of medulloblastoma came to be described. Randomized trials actually started way back in 1970s when cytotoxic chemotherapy started to be used and the survival increased. By early 2000, the genetic actually mutations of medulloblastoma, recurrent mutations in the SHH, Winch gene pathways started to be discovered. And by early 2010, multiple research groups found out that there are definite genetic signatures in medulloblastoma and divided into subgroups as we know it today, that is Wnt, SHH, non-Wnt, and non-SHH. So what is the WHO classification? The latest one classify medulloblastoma into. So medulloblastomas, as previously was histologically defined, now has been molecularly defined into the Wnt activated, the SHH activated, and the non-Wnt, non-SHH activated. The SHH type has again been differentiated into P53 wild type and mutant type. And we all know that the SHH activated P53 mutant type is a very bad prognostic type. The previous medulloblastoma classification, as we know, is classic histology, and two types of the classic histology, that is the DN and MBEN, that is extensive nodularity, and the uniformly poor prognostic histology, that is a large cell anaplastic medulloblastoma. So it's a small blue round cell tumor with classically the homerite rosette seen in microscopy. And we have two variants, that is the desmoplastic nodular medulloblastoma, which is usually seen in the adolescent and the adult population, and the MBEN, that is the extensive nodularity type, which is seen in the very young children. So classically, if you see immunohistochemistry as against most CNS tumors, these are synaptophysin positive. And what has changed in brain tumors, that's the accurate classification as well as typing of brain tumors, is this genetic method, that is DNA methylation profiling. And in medulloblastoma, this has helped us find out 4 distinct genetic signatures. And we know that nowadays we divide it into the Wnt pathway type, SHH type, and group 3, group 4 type. And this is on your left side, you can see the gene profiling that we get when we send for genetic typing of medulloblastoma. So classically, I think most speakers have put the slide, that is classically the Wnt pathway, which is the best prognostic type and usually seen in older children and adults, and the SHH type, which usually has an intermediate prognosis, the group 4 type, which also has an intermediate prognosis and which is seen usually in older children. If you see, the commonest type is group 4, which constitutes around 35 to 40% of all tumors. And the most rare type is the Wnt pathway tumors, around 10%. But this is the best prognostic. And group 3 and SHH constitutes 30% each. So the majority of tumors that we'll see is usually the group 4. So in India, since we have limitation of genetic DNA methylation studies, this study actually showed us how to differentiate it between the 3 types by using immunohistochemistry. So in immunohistochemistry, GAB1, YAP1, and beta-catenin is usually used for differentiating these 3 types of tumors. So if you can see in the slides, adults have mainly the SHH type, so as to infants, and children, mainly it's the group 4 type. Among the survival, this actually Cool et al. Study actually showed us that Wnt pathway has a very good survival and group 3 has the worst survival with the intermediate survival in the group 4 and the SHH type. Classically, the risk stratification in medulloblastoma has been with the age, that is more than 3 years having average risk and less than 3 years high risk, residue after surgery, and the metastatic, non-metastatic, along with the histology, that is large cell anaplastic, having the, the high risk part, and the average risk being the standard classical medulloblastoma. So this, in pediatric tumors, most of the time, we tend to risk stratify any tumor and try to give a lesser treatment to the average risk and higher intense treatment to the high risk category. So all of us know that the management of medulloblastoma was mainly by the Packer et al. Group. And many of the regimens actually are called the Packer et al. Regimens. There were 2 studies that the Packer et al. Investigators actually put in, and they actually changed the management of medulloblastoma. This is one study in average risk medulloblastoma in which craniospinal RT and the use of adjuvant therapy, that is along with vincristine during the craniospinal treatment, as well as adjuvant treatment, changed the management of medulloblastoma. And as you can see here, a 5-year survival of 81% in non-metastatic setting and a survival of 36% in the metastatic setting, which achieved. So we know this regimen as the classical Packer regimen. So these contain three drugs, that is CCNU, cisplatin, and vincristine. The other, regimen that is used in medulloblastoma is the cyclophosphamide, BCR, and CDD, the cisplatin regimen. Many of us use this regimen because of the erratic availability of CCNU in the market. So Packer et al. Regimen is universally used still as the adjuvant treatment of medulloblastoma. So what is the standard of care? Surgery followed by craniospinal radiotherapy with a posterior fossa boost along with weekly vincristine for a period of 6 weeks. It has been shown that this adjuvant treatment should be started within 40 days of surgery, and beyond that, this would adversely affect the prognosis of the child. This, after 4 weeks, we start the adjuvant therapy with one of these regimens that is standardized. So what are the radiotherapy guidelines? In standard risk, we use more craniospinal radiation, approximately around 23.4 with the 13 fractions. And in high risk, we use 36 gray with over 20 fractions. The posterior fossa boost was the classical treatment that is given for medulloblastoma. And this would reach up to 55.8 gray over 31 fractions. So what has changed in the recent, I'll come to that later, but what has changed is probably this posterior fossa boost in standard risk and average risk, in which we are able to restrict it to the involved-free RT or tumor radiotherapy. So what are we bothered about in medulloblastoma? It is the late neurocognitive sequelae associated with the craniospinal radiotherapy of medulloblastoma. So what are we looking at in recent advances? One, better risk stratification, so that probably in some group of these patients, we can come down on the treatment, come down on the doses of treatment, that is de-intensification of treatment in low risk and intensification of treatment in poor risk, including the use of newer agents or molecular agents. So this is, I think this has been shown by many of the speakers here. So a lot of groups have started subclassifying our 4 molecular subgroups. As you can see this, Cavalli et al. Group has divided into 12 subgroups. This is another Schwalb et al. Study in which they have divided into novel subgroups. And what they have done is they have divided it into favorable risk, in which the radiotherapy doses can be decreased, and higher risk in which better agents can be used. So from classical, the medulloblastoma risk stratification as we know it, now most consortium risk stratifications use this magic consortium stratifications. I'll try to stress upon 2 parts of this risk stratification. One is the low risk. If you can see, the survival is more than 90%. And in this group comes the non-metastatic WNT. As we know that WNT pathway tumors, which are non-metastatic, do very well. And along with this, in the low risk category is the non-metastatic group 4 with a chromosome 11 loss. Why this is important is in the treatment and whether we can de-intensify this group of patients. The other group of patients is the very high risk group. If you can see, the SHH pathway P53 mutant tumors, do very badly, and our experience also with these tumors have been very poor. Along with this is the metastatic group 3 tumors. We know that group 3 tumors are, poor prognostic groups, as well as when they are metastatic, they tend to be more they tend to do worse than the rest of the group. So these 2 tumors are the groups that probably we can stress upon, and one de-intensify while intensify the very high risk group. So the risk stratification is helpful in probably modifying our medulloblastoma trials. As you can see this, I'll come to this in the later studies, but this slide shows that probably this study looks at risk stratifying medulloblastoma into many strata, de-intensifying in the best strata, low risk group, and increasing the treatment as well as use of molecular agents in other high risk groups. So the first strategy of de-intensifying, this is the classical trial that came out from the COG group in average risk neuroblastoma, in which they tried to decrease the doses of radiotherapy given to decrease the toxicity associated with chemotherapy. So there were 2 randomizations in this study. One is decrease the CSI dose from 23.4 to 18 gray. And the second thing is decrease the boost to the posterior fossa to involved field radiotherapy. That is, decrease the toxicity of radiotherapy by decreasing the field of radiotherapy. So what were the results of this study? If you can see, it was seen that in average risk medulloblastoma, we could decrease the dose of radiotherapy to the involved field RT in average risk neuroblastoma. There was no difference in the event-free survival or overall survival in both these groups. So nowadays, in average risk medulloblastoma, we don't use the posterior fossa boost, but we decrease it to involved field radiotherapy, that is tumor boost alone. What about decreasing the RT dose to the craniospinal component from 23.4 to 18 gray? It was shown that, as you can see in these figures, that there's a clear decrease in survival when you decrease the dose to 18 gray. So it has been clearly shown that in average risk, you cannot decrease the radiotherapy of the spinal component to 18 gray. So what else can we do? Investigators have tried to find out a better group of average risk patients. That is, we know that Wnt medulloblastomas have a better survival. So in the average risk medulloblastoma, they have tried to take out the Wnt group of medulloblastomas and try to decrease the dose of radiotherapy. So there have been 2 pilot, 2 studies which have been done in this Wnt group, one with omitting radiotherapy, and the other with totally not giving the craniospinal component, giving the boost alone to the tumor bed. Both are negative studies in that both of them had a very high local recurrence as well as metastatic recurrence. The second study of decreasing the craniospinal component was from India. So what are investigation? So we know that we cannot decrease the dose of the spinal component. So the second question was, in Wnt type of medulloblastoma, can we decrease the dose of the craniospinal radiotherapy? So this study from the St. Jude's group in Tennessee, United States, what their primary objective was to decrease the dose of spinal component to 15 gray, along with decrease the doses of chemotherapy. What was seen that the Wnt type of medulloblastoma, when you could decrease the dose of craniospinal, had a high survival irrespective of the dose, whether it was given 23.4 or 15 gray. So we know that in Wnt pathway tumors, we can decrease the doses of radiotherapy. So there were 2, limitations of this study. One, the number was very small, and their follow-up was very short, approximately 3 years. So at present, there's one study by the COG group, that is Children's Oncology Group, which is looking at average risk Wnt tumors, decreasing the spinal 18 gray, no VCR in the induction, and decreasing the doses of chemotherapy in the adjuvant. So once these results are out, probably we will be 100% sure whether we can decrease the doses of radiotherapy in Wnt pathway tumors. The other group of tumors that are being studied, as I said, is the low risk group 4 chromosome 11 loss tumors, in which again the craniospinal, they're trying to decrease the CSI component to 18 gray. So 2 low risk tumors in which investigators are trying to decrease the dose of CSI from 23.4 to 15 to 18 gray. What about high risk tumors? So can we intensify the treatment in high-risk tumors and improve the survival? So this study, which was published in 2021, introduced carboplatin during the craniospinal component. That is, along with vincristine, carboplatin is added into the regimen. So what were the results of this study? So as you can see, there was a definite improvement in the survival in the carboplatin group as against the non-carboplatin group. And they divided it by molecular subgroups, and the maximum survival benefit with the addition of carboplatin was seen in the group 3 patients. So at present, we know that the group 3 patients have a poor survival, and group 3, P53 mutant, the group 3 and the SHH P53 mutant have a very poor prognosis, and improvement with carboplatin in this study has shown that, and most of us use carboplatin for these group of patients who are high risk medulloblastoma during the craniospinal RT along with vincristine. So this study from the St. Jude's group, as I have shown previously, this is the first molecularly stratified medulloblastoma study. So Wnt, SHH, and the non-Wnt, non-SHH groups are further stratified into low risk, intermediate risk, and high risk. And then the doses of radiation are decided depending upon the risk stratification. What is significant in this study is the use of molecular agents. So as we know, the SHH group, especially the P53 mutant, has a very poor prognosis, and it is the first study in which a molecular agent is being used in maintenance therapy. As you can see, the SMO inhibitor is being used in SHH subgroup for improving the survival. So this is this is the first time probably a molecular agent is being used in the adjuvant setting in medulloblastoma. So there have been a lot of agents that have gained interest in medulloblastoma, like the SMO inhibitors, which is vismodegib or sonidegib, the HIDAC inhibitors, that is the PI3K inhibitors, the BET inhibitors, the LSD1 inhibitors, the CDK4/6 inhibitors, because all these are involved in the pathway of medulloblastoma. So I'm sure in the years to come, probably we'll see all these agents being used in the adjuvant setting. So in conclusion, medulloblastoma, the primary treatment, of course, is multimodality treatment. And in pediatrics, it's risk stratified, decreasing or minimizing long-term toxicity, because in pediatrics, most of the children will be long-term survivors, and you want to decrease the long-term toxicity. So the aim of treatment would be to come down, de-intensify treatment in low risk, increase the intensity, use of newer targeted agents in the adjuvant setting. I think that would be the, we'll be seeing all this in the years to come. What I've not touched upon is one, the use of proton therapy versus photon therapy, because I'm not an expert in that field. And second is the use of autologous BMT. Though many of us advocate autologous BMT for high-risk situations, for young children in relapsed refractory setting, its role in the consensus guidelines of medulloblastoma is not very clear. Thank you. And thank you once more for giving me this opportunity.
Thank you, Dr. Yavini, for a wonderful talk and opening the window towards all the explosions that are going to come in the field of chemotherapy. Now, it's a time for the panelists and for more elaborate discussion. I'll invite Dr. Majumdar to introduce the panelists and initiate the panel discussion.
Thank you, Matthew. Before I start the panel discussion, I should introduce Matthew formally, which I have not done. So Matthew, as I told you, has been a great teacher, and he completed his neurosurgery training in 2002 from Sri Chitra Tirunal Institute of Medical Sciences, and he was a consultant since in the same department in 2003, and he's been head of neurosurgery there, a professor and head since July 27, and he now heads the neurosurgery department at the DC Hospital in Ernakulam. So quite a distinguished career, and in addition to that, he has his fellowship from the Royal Melbourne Hospital in Melbourne in 2009. His interest includes, as everybody knows, epilepsy, skull base, and cerebrovascular surgery. So with this, I think we can go to the panel. And we have two distinguished guests here, which also need actually no introduction. Professor Suresh Nair, everybody knows he was the former head of neurosurgery at the Sri Chitra Institute of Medical Sciences, and a voracious teacher, learner, and he's been the president of NSI, president of the International Meningioma Society, numerous publications to his credit, and still we see his ardent presence at each and every meetings, and he really touches upon the basics in clinical neurology and as well as the advances in neurosurgery, and always trying to learn and share his experience. Our second esteemed panelist is Dr. Deepak Gupta, who also is a professor of neurosurgery at All India Institute of Medical Sciences, and he has an experience of last 25 years. His main interests include as everybody knows, pediatric neurosurgery and spine, mainly CV junction, and he's got his key achievements, which are, as everybody knows, that he was involved in the craniopagus separation of twins with Professor Ashok Mahapatra, and those two twins are still alive and they are doing well. He also leads the organ donation program at the JPN Apex Center in at the AIMS, and he has about 356 publications, and to his credit, with 3 books as editor. So let us kickstart the discussion. Can I invite Professor Nair for his comments?
I think I will give it to Deepak first, and after that I will come.
Okay,
Deepak.
sir. Okay, Deepak, I think the three
so much.
presentations have been very good, and they have covered the topic very well. So Deepak, can you he's the current president of the Indian Society of Pediatric Neurosurgery as well. So Deepak, your comments, please.
Yeah, so I think we had a very comprehensive webinar covering almost each and every aspect of medulloblastoma. In fact, Dr. Majumdar began with a very basic, how the medulloblastoma used to be managed 30 years back. I have a few questions to our speaker. My first question is to Dr. Suresh Bapu. Sir, what is your take on insertion of Omaya intraoperatively in very young children? Like, do you do it as a routine or only in very select cases? Let's say you have a child less than 3 to 5 years of age with intraop frozen or findings suggestive of medulloblastoma. For intraventricular chemotherapy later on.
No, we have not used Omaya
So
reservoir. We have used Omaya reservoir only when there is some infection and we have to give antibiotics. Otherwise, to instill oncologic therapy, we have not used that.
Dr. Yamini, what is your take on that? Because at our center, the more and more patients, very young children that we operate, there's always a request from our medical oncologists in the tumor board to insert the Omaya chamber. And now I have made it a routine in very young children. I actually insert Omaya intraoperatively to avoid second surgery. Like, what is your practice and advice of Omaya in very young children?
So there are some study group. Am I audible?
Yes.
Yeah,
Yeah. So there are some study groups in which we use, intraventricular chemotherapy, like the HIT protocols, So it depends upon what your pediatric oncologist is comfortable with. So if they're using the HIT protocols in medulloblastoma or any pediatric tumors, we go by protocol-based treatment, whether it be leukemias, solid tumors, all are protocol-based. So if your pediatric oncologist is, comfortable with the intraventricular regimens and the HIT protocols, I think means it is worth it using that protocol. We use mainly the European protocols, which have high dose methotrexate and other drugs. We don't use much of intraventricular chemotherapy. We use more of high dose chemotherapy and autologous transplant in these children. So it just probably depends upon what protocol you're comfortable with and which protocol you're using.
And is Vismodegib available in India and this smoothing inhibitors? And how expensive is it like?
I have no idea because I have not imported, but most drugs are imported in India. So we have been using a lot of targeted agents these days. So I think if it's available in the West, I think it should be available in India because most of these drugs are imported and not marketed in India.
Okay. Dr. Suresh Bapu sir, you covered very nicely about the surgical steps, about various approaches, how to reach the lesion. But for youngsters, what is your advice? My very basic question would be telovelar versus transformian in medulloblastomas. What is your advice to the youngsters?
Most of the tumors, they present themselves either in the cisterna magna itself, or when they split the tonsils, separate the tonsils, the tumor will be seen. We just debulk the tumor and keep going. This is required only when most of the tumor is confined to the in the fourth ventricle and not seen. Only in such cases you need this telovelar approach or transdermal approach. To youngsters, I will say it is maybe much easier for them to do a transvermian than a telovelar approach. That will be my recommendation. Only thing is they have to make sure that they don't split the vermis too much. Keep it minimum and expose the tumor and keep starting debulking and go in the interface between the tumor and the brain and remove the tumor instead of going for but if the tumor is more laterally placed, we will not be able to do that. In such cases, we'll be forced to do the telovelar approach.
So how do you routinely do the surveillance of your patients? Like we have been taught by, and this is what we are teaching in the first year, every 3 monthly you do the surveillance, but after 1 year, we don't have any clear guidelines. How should we screen? Should MRI screening of the spine be a part of the screening after 1 year of surgery or not? Or like what is the current practice? Maybe you or Dr. Bijoy could answer this question. After 1 year of the surgery and chemo radio for medulloblastoma, do you really routinely screen spine MRI with the brain MRI?
We do routinely all the patients every year. Annually, we do the whole brain and spine screening. Or if there are new symptoms, we don't wait for 1 year and do it earlier. That has been the policy for us.
Okay, thank you. Dr. Vijay, anything you want to comment upon this?
Sir, I am not aware about after 1 year what is the real protocol. But I think whenever we are doing, we have to do the whole brain and spine, because another very important thing I want to emphasize is that before surgery, if it is possible, we have to do a spine screening, because after surgery, there is always intracranial hypertension, and the epidural venous congestion can actually mask very subtle dural metastasis. So it is always better, even when the patient is sick, intubating a patient and doing a spinal imaging before surgery is very important. After 1 year, I think it is debatable. I think every institution has got their own protocol. I'm not very sure about what exactly is the protocol.
Can I put in a...
And yeah, please.
Yeah, so what we follow at our institute is clinical examination every 3 months, imaging with MRI brain and spine screening every 6 months. We tend to do it until 2 to 3 years because that's the maximum time of recurrence, and then we do it yearly until 5 years. And of course, whenever symptomatic, we would, repeat the MR and spine screening.
And before I hand over to Dr. Suresh, Dr. Bijoy, what is the role of CT scan in the present era? I mean, India is very vastly heterogeneous population. We have been talking about all the advances of MRI technologies available. Of course, it has not changed upfront the surgical decision making for the surgeons. The management remains gross total resections. But there are certain centers in our country wherein they may not have access to DW and ADC and other advanced sequences. So what do you think is the role and in the management of tumors?
I think as far as possible, we should avoid CT scan, sir. That is in pediatric, as all pediatric cases, I think we should avoid, especially below the age of 5 years, even a single CT brain with a pediatric dose reduction. It can produce a long-term cognitive outcome. It has been studied in the Nordic countries. So, and also medulloblastoma, already mutations are there. I think it is not a good idea to irradiate these children because I'm not sure whether these they are prone for more mutations. But I think and CT, we are not going to gain anything rather than actually giving a diagnosis. So surgery obviously requires an MR, and now most of the places MR is available, but many people say because of the cost advantage, they will do an CT scan first, even when MR is available. That I think at least that practice should be avoided. Having said that, our MR penetration as a country is very, very low. We have we have less than one MR unit for 100,000 population. America has got almost 50, and Japan, I mean, America has got almost 30, 35, 40. Japan is the highest, I think 55 per 100,000 population. So more and more MR units as it gets available, because it is getting manufactured in India also now. So I think we should totally avoid CT scan in these cases.
One thing which none of our speakers somehow cover, and I think Dr. Suresh Babu is the right person to answer this question. Child with medulloblastoma presenting with hydrocephalus. Do you avoid shunts as Dr. Muzumdar talked about, or do you do early shunt and then tumor under controlled conditions, tumor excisions, sir?
Yeah, we avoid shunt especially for medulloblastomas. We avoid. I mean, because as Dr. Majumdar said, now we intubate the patient if the child is okay, and straight away take them up for surgery and do external ventricular drainage and do the surgery and leave the EVD for 24 hours or so, measure the ICP and then remove it. So we avoid VP shunt. ETV, we have done very select patients in these patients. As I said earlier, no, suppose the patient has to be taken out of India, and then they continue treatment someplace as an emergency procedure to gain in time for a few days. We have done ETV. Otherwise, we don't do shunt. Of course, in some of these patients, post-operatively, they have required shunt. It has been shown that in 10% of the patients, there are some good Indian articles also in that post-operative tumors, if there had been some infection or even without infection, persistent hydrocephalus is possible, and they may have pseudomeningocele, and such complications may require delayed VP shunts even after 2 weeks or so. So we avoid VP shunt otherwise.
Altogether. Okay.
I have seen patients who have developed peritoneal metastasis, these big tumors. So definitely we should avoid a VP shunt.
Thank you. I hand it over to
Because I would agree with Dr. Bapu, Suresh Bapu. The only problem with the VP shunt which we felt when we did is that the CSF cushion which we can utilize during surgery gets compromised. So what happens is after shunt, the tumor progresses more towards the brainstem and can get adherent to the brainstem, and subsequent surgery can be more challenging. So we have to make, if possible, that correctly he mentioned that, and you also know, you also practice the same thing, that we either do a EVD or do an intraoperative burial, get that thing under control, and then probably proceed with the tumor exchange. That CSF cushion around the tumor is extremely important.
No, we have a different practice actually. The reason being the workload. We must understand in very busy centers wherein the waiting list of the other patients is quite high. Sometimes we end up putting in shunts to buy some time for the surgery.
Yeah.
So, I mean, technically speaking, it's very, very valid and good suggestion that shunt should be avoided as much as possible. But at times in busy setups, if we have to buy time, sometimes we do put in place BP shunts. But a very strong message which Dr. Bapu gave and I which really liked so much was sometimes the children do deteriorate while getting the investigations done, and they so one needs to be very, very careful to in such drowsy or kind of patients with large tumors. It's always better to intubate them and get the investigation done. I think most of the questions have been answered very, very nicely by our by esteemed speakers. Maybe Dr. Suresh Nair could add to
Thank
what has
you.
already
There is
been.
no questions because an excellent talk by all the three speakers. Bijoy, of course, we have worked together for many, many years. And Suresh Babu was my mentor. We studied MCS together, but I learned a lot from him. And Yamini, first time I am seeing you, what an excellent lecture. Let me comment about all the three speakers' lectures. And if you can spare with me, I want to show some 5, 6 slides. Let me start with Bijoy. And what a lovely talk, Vijay. He started by saying that real estate rule, that is location is prognosis. Not only he told us about the location of WNT, SHH group 3, group 4. He also told about the embryogenesis of WNT and SHH medulloblastoma very nicely. And he told ADC mapping is very important. And normally, other tumors other than medullo, it will show a ADC of more than one. That is what I understood. More importantly, what I learned today is that WNT can show hemorrhagic features. Edema is more for SHH. And group 3, usually they are smaller tumors compared to group 4, they are midline in location. Sugar coating is for group 3 tumors. And these are, and he also told the importance of, especially, group 3, it can have metastasis everywhere. And craniospinally told fat saturated sequence is very important. He just told about the importance of perfusion imaging, not much. And also he showed a case of which was looking like a ependymoma, very heterogeneous signals. No, uh, there was no diffusion restriction extending through angle. But only clue was he told it was hyperdense on CT scan, plain CT. So plain CT hyperdense will give us a medulloblastoma diagnosis. It was a lovely talk, and Suresh Babu's talk, of course, he told about clinical presentation and timeline evolution of medulloblastoma management. But always I used to ask residents as one question. So all these tumors can occur in children. Below 10 years, and you enter the pediatric ward, you see somebody with a neck tilt. What is your diagnosis? All three have got three different posterior fossa tumors. One fellow has a neck tilt, other fellow has a seventh with sixth, another fellow has got both the eyes are looking inward. All three, and gives you a diagnosis without even examining the case, because medulloblastoma will have that neck tilt, Wilson's sign, what we call, because fourth nerve can get involved. Not always. Sometimes it will have, they sit, handsome kids, and many a time these kids are so handsome also. They come and with a neck tilt. And say that ependymomas, we know, group 3, type A is the one which comes to the midline. But suppose it infiltrates the fourth ventricle, they can have sixth, seventh. So suppose somebody who has got sixth, seventh, it is more likely it is a ependymoma. It's old teaching. And with inward eyes, of course, it is a brainstem glioma. So he told about clinical presentation, timeline, evolution. He told the importance that, of getting MR done within 2 days after resection. And also he told about some British study where the importance of total resection is for only for grade 4 tumors, sorry, grade 4 medulloblastomas, and not for WNT and SHH and group 3. Group 3, not grade, group 4 medulloblastoma. And he told that one should try to start craniospinal irradiation within 3 weeks. He told about cerebellar mutism. Incidence, of course, is 0 to 15%, even with telovillar approach. But he told it is more with a midline vermis splitting approach. And also he told about 7 Tesla MR. You can map the dentate nucleus now. And he told you can stimulate the dentate nucleus and it will inhibit the MEP responses. Maybe in future you can map a dentate nucleus intraoperatively. And what else he told? I think he covered everything. And Yamini, of course, she told everything about the current treatment. She told about initially with craniospinal irradiation with posterior fossa boost and vincristine 6 weeks. She told about MAGIC consortium risk stratification. And she told about high risk and low risk groups. And also she told about the latest NGO people, what they have done with 2 types of tumors, like that de-escalating irradiation for WNT group and medulloblastoma with chromosome 7 loss with craniospinal from 18 to 15 grade. And also about, she touched on the SMO inhibitors for SSH medulloblastoma. If you have time, can I show some slides?
Yes, sir.
Okay.
Sure.
Okay. Let me see, it is there. Yeah. Are you seeing my slides?
Yeah.
Yes, sir. Yes, you are seeing your screen.
Well seen. Okay. Let me, I'll put. I'm sorry, somewhere it went. Okay. Some tumors which many of these things have been told. I will skip everything. Don't worry, I won't
We are
bore
not
you.
seeing your screen. Sir, we are not
What is
seeing your slides.
You are not
You
seeing.
just say black.
Only says saying it is black. It is saying it has started screen sharing.
You are not seeing now.
No, we are
Right,
not. Sir, you can start again. Stop and start again.
Okay, you are not seeing my slides.
No, sir.
Let me stop share. Let me
Ah.
stop share. Let me share. Okay. Share.
Yes,
Yeah,
yes.
now I can see.
Seeing?
Yes, yes, sir.
Are you seeing?
Yes,
Yes.
sir.
Okay, so this was a cold morning in Trivandrum. So when I get a call from Delhi, so this was, doing a CPC in All India Institute is like writing 5 papers. Deepak may be knowing.
Yes.
So I was told, call from All India Institute, can you do a CPC there? The second time they are calling me for CPC. First time it was Chitra Sarkar in 2010. And this was 22. Sharma, Dr. Sharma, pathology invited me. Very, see what they have written. They scribbled something like this. And then this is one image they gave. And I will tell about this image, which is a tumor which Bijoy alluded to, but I will tell this. This is all nothing, not relevant for this discussion. I will skip all this. You are seeing all this, no?
Yes.
So this was an intrinsic pondine lesion with dorsally exophytic component. And this was, specks of calcification, microcalcification. Say, in posterior fossa tumors, in pediatric group, say, location is very important. You have to see whether it is in the cerebellum, or it is in the 4th ventricle, or it is in the brainstem. So if you have something in the brainstem, say diffuse, you can have most of the things are in pons, which are very high grade gliomas. HBK, ഞാൻ അങ്ങോട്ട് വിളിക്കാം, ഡിസ്കഷൻ ഇരിക്കുക. There S3K27, that histone alteration is there. But we all know that intrinsic pondine gliomas are very malignant and they engulf the basilar artery or whatever it is, more towards the ventral aspect of brainstem. And otherwise, you can get pilocytic astrocytoma also in the pods. Very rare. Mostly they are in other locations. But in medulla and in mesencephalon, you can get say low-grade tumors, pilocytic astrocytoma, usually in mesencephalon and in medulloblastoma. But I think Bijoy or somebody told about MAPK altered. Say you don't hardly ever see a grade 2 astrocytoma in the infratentorial compartment in children. That is the diffuse glioma which we see in supratentorial compartment. You hardly ever see posterior fossa. But now they have described in the medulla and other places MAPK altered tumors which can occur in medulla where the borders are not very sharp like what you see in medulla in other pilocytic astrocytes. So come back to this. This is, you know, it's a 2-year-old child with specks of calcification. This is a circumscribed lesion, more dorsal, unlike a pontine glioma, which is more ventral and engulfed. This is more dorsally exophytic. T2 flyer hyperintense lesion, and this is the gradient showing calcification and very subtle enhancement. So this is a well circumscribed intrinsic pontine lesion, dorsal exophytic component, a pontine lesion with high cellularity and few calcification. So many possibilities we considered. I presented. I don't want to go for that. Ultimately, we knew because of some diffusion restriction, it was it should be embryonal tumors. And very nicely, all of them have told about classification. I don't want, but I want to show this picture. This picture I got from Sharma, All India Institute professor. Why this rosette thing came? It came from a cathedral rose window and cathedral basilica of Saint Louis. And this is the basis of our rosettes. Just everybody should know, everything has been told. I don't want to allude to this. And this was the tumor, which my CPC was embryonal tumor with multi-layer rosettes. Previously, you know, as was told, say they included ETA, NR, ependymoma, blastoma, but now it is invariably, it occurs in less than 4 years and mostly less than 2 years. Other tumor which can occur very young is ATR, atypical teratoid rhabdoid tumor, which is also a tumor occurring in the age below 5 years. And this can occur, ETMR can occur anywhere. It can occur in the brainstem also. And it can have calcification, tumor density, CT variable, and CS of cerebral blood flow using ASL is low, but relative CBV high. This differentiates from other tumor. And this is other things, alteration is in C19 locus. So, and this is the histopathology, and people have found that C19 MC amplification and expression of LIN28A are the thing. This is so many papers have come, but how do you differentiate it from other posterior fossa tumors? You know, say between 1 and 4 years, juvenile pilocytic astrocytoma, strong enhancement, no diffusion restriction. Ependymoma, you know, Bijoy told we can get fooled also. So it is very heterogeneous tumor, no diffusion restriction. When all embryonal tumors can show, will irrespective of the degree of enhancement, you know, group 3 enhances, group 4 medullo don't enhance, but all of them will show some diffusion restriction, unlike that case, one case Bijoy showed. And this is the differentiating feature between ATRT and medulloblastoma. ATRT will have multiple cysts around, which is uncommon for. I have that picture. I have to give a talk next week in Hyderabad, but I thought Bijoy will be showing that picture. So, so this is, you know, contrast uptake of ETMR is low compared to ATRT. Cerebral blood flow of ETMR is low, while medulloblastoma and ATRT have high ASL. This is another tumor which can occur in the posterior fossa. So this is a ECP expression posterior fossa ependymoma. This can occur in the brainstem. It can mimic a pontine glioma or even a ETMR. So other diffusion restriction tumors which can occur rarely are lymphoma, germinoma, and also one should think of non-tumors. All these things can also mimic a brainstem tumor. And I think it was alluded to DTA, role of DTA, and I will skip. This is one picture I want to show. Let me minus this picture. This is a very good thing. Say age, this is, pediatric age is infant, school kids, teens, and adolescents also. So, pilocytic astrocytoma can occur in all age groups, but mostly it is in teens and school age. Medulla, you see, school age kids and infants also. ATRT in toddlers, infants only. Ependymoma, A is in infants, toddlers, B is little more elderly group. And this is, location is very important. Hemisphere, it is pilocytic astrocytoma, SSH medulloblastoma. SSH can occur in vermis area also. And this is fourth ventricle, it is medulloblastoma, ATRT, ependymoma. Brainstem, diffuse glioma or other tumors I told. And this is again pilocytic astrocytoma, SSH medulloblastoma, ATRT. They can occur in the hemisphere. Brainstem glioma is separate. Medulloblastoma in fourth ventricle, ATRT, PFB, ependymoma. Luschka involvement, medullo, ATRT, and ependymoma group B. And this is, nodule with cyst is pilocytic astrocytoma. Diffusion restriction, it is medulloblastoma or ATRT, but sometimes anaplastic ependymoma can also show diffusion restriction. Plastic growth pattern, go like a paste, engulfs the brainstem, coming out of Luschka, coming through Megendi. Plastic growth pattern is characteristic of ependymoma. And this has all been told. I don't want to, these things have revolutionized our I think I'll skip all this. And now, personalized treatment, de-escalation, which Yamini has told, pathways she has told, all of these targeted therapy are coming. And in future, I think these things will change management of medulloblastoma. And mutism, Suresh Babu has told also. Thank you very much. Let me unshare here. Thank you very much for,
Thank
and
you, sir.
anything I can
I would
answer
just
also.
like to mention one thing about cerebellar mutism.
Yeah.
All of us operate cerebral posterior vasa tumors and with great degree of accuracy and a lot of care. But the incidence of cerebellar mutism, which is about 10 to 15%, we see a great deal of cerebellar mutism in spite of good surgery. And the reason being that it is not always we blame the dentate or rubro-thalamocortical fibers. Yes, it is the substrate, but the most important factor is that it is a vascular perfusion defect. So because of the tumor and the subsequent intervention, there is a transient or a delayed cerebellar perfusion, hypoperfusion, and that is the cause of the cerebellar mutism. So the less of retraction we do, the more care we take, we just reduce the incidence of cerebellar mutism and the long-term which effect which Dr. Suresh Babu has told correctly, that everything resolves, but the dysarthria may remain. So that cerebral mutism should be taken very, very seriously, and counseling should be done preoperatively to the patient's relative. That it's a tumor also which is responsible for the cerebral mutism. And it has been shown that medulloblastoma causes more cerebral mutism than astrocytoma and ependymoma in the same location. If you operate an ependymoma or astrocytoma, there may not be any cerebral mutism, but medulloblastoma definitely is the cause of cerebral mutism. Thank you very much.
Exactly.
Over to Matthew. Matthew, I think
it almost never occurs for a pilocytic astrocytoma.
yes.
It's always for a medulloblastoma.
Yeah.
I had a question to Dr. Suresh Babu and Yamini. Sir, you said that after a medulloblastoma excision, you will always take an MRI within the next 48 hours at the earliest. Suppose you find a 1 centimeter residual or 1.5 centimeter residual. Will you go back again, or will you wait till you get some form of molecular marker, or you may accept that? What approach will you take if you find a residual after an excision? And to Yamini, maybe I'll the second part after her answer.
Yeah, it's a good question. If the tumor is small, residual tumor is small, I think we leave it behind. So it is much easier to locate a big tumor than a small tumor. So the reason why it was left behind matters a lot. Supposing it has been left behind because it was adherent to the brainstem or to the peduncle, and then there's no point in chase the tumor and remove it again. But it has been inadvertently it has been left behind, and the tumor is large. There is definitely a place for revision surgery and remove it. But I have not done that.
Okay. To Dr. Yamini, suppose you find a residue in a patient who has been operated for a medulloblastoma, small, maybe around a centimeter. Would you send it back to the surgeon to consider a resection?
So I wouldn't, sir, because medulloblastoma is highly, radiosensitive tumor, and many of the times we have seen even residues in the tunes of 1.5 centimeters square having survival. So I wouldn't, for small residues, I wouldn't. But if it's a biopsy alone and you have a huge residue, I would definitely send for a re-surgery.
Yeah, I have one more question. That is, suppose while a patient is waiting for the surgery, waiting for the radiation, you find that there has been a progression of a tiny recurrence. Very often in larger setups, the patient has to wait a long time before they get radiation. There is a progression by maybe to around 1.5 centimeters. Will you consider a re-excision, or you will go ahead with?
I would still go ahead with radiation rather than going for surgery.
Okay.
Because
suppose you are having a recurrence of a lesion. You said you will go on following up a patient every 6 months initially and every year. A late recurrence of a medulloblastoma, would you send it for a resection without obstruction, without any CSF obstruction? With obstruction, the answer is straightforward. There is no obstruction, but you have a sizable recurrence in the posterior fossa.
so we advise
suppose the situation is that you have given only a posterior fossa boost and you're having a recurrence in the spine. It's a WNT. What will be your recommendation?
So we advise surgery in when the patient has a long disease-free survival, that is more than 1 year. If it's a localized disease, amenable to surgery, and there's no other metastatic, foci anywhere, we would still advise surgery. But if it's a long DFS, so our practice has been, we'll try to, resect if it's a late recurrence and a single site of recurrence, give re-RT, give auto transplant, and give some sort of maintenance for a year. Because we know that they do invariably very poor. So in a metastatic disease, medulloblastoma, the survival has been in the tunes of 10-15%.
So is it necessary to make such a strict follow-up?
I don't know, because invariably the survival is very poor. So we know that medulloblastoma has a survival of 10-15%. And there are some studies that have done auto transplants and re-radiation surgery, which have given survival in the tunes of 25-30%. So we do advise in long DFS surgery done, we re-RT, and then do auto transplant with a sort of a maintenance for a year.
Okay. Thank you. I don't think there are any questions in the chat boxes. So I think it was an excellent session with everybody, very, very active discussion. Thank you all speakers and the panelists. And I think we come to the end of today's session.
Thank you, Matthew. Thank you, Vijay, Suresh, Yamini, and my best friend Datta, Deepak, Sundar, and I am seeing Vijay Segar also very active. Okay, thank you all. Until we meet next time.
Thank you. Thank
Bye.
you. Thank you, Matthew.
Have a great Saturday evening.
Bye. Bye. Thank you.